Hello and welcome back to Chapter 16, Medications and Electrical Therapy. In today's lecture, we're going to talk about electrical therapy. Electrical therapy involves utilizing electrical stimuli to either speed up or in some cases slow down the heart rate or to shock the heart out of a dangerous or unstable rhythm. There are two kinds of electrical therapy that we'll be talking about. We have artificial pacemakers, which we have traditional and cardio resynchronization therapy. Then we have cardioversion and defibrillation. A pacemaker is an artificial device that electrically stimulates the myocardium to depolarize, which begins as a contraction. Pacemakers are used for bradycardias caused by sinus node dysfunctions, medication, or atrioventricular block, cardiac dysynchrony due to advanced heart failure. This device may be temporary or permanent depending on the patient's condition. Pacemakers are commonly necessary for the aging heart and following myocardial infarction or cardiac surgery. Another use for pacemaker is anti-tachycardia pacing, also called overdrive pacing. This special programming function on some pacemakers allow the pacemaker to interrupt a tachycardia by interjecting a series of pace beats in the middle of a tachycardia, thus interrupting the rapid circuit and allowing the sinus node to resume control. Pacemakers work by generating an impulse from a power source and transmitting that impulse to the heart muscle. The impulse flows throughout the heart and causes the heart muscle to depolarize. Pacemakers consist of three components. You have a pulse generator, the pacing leads, and the electrodes at the tip of the pacing leads. Here are a few indications as to why a pacemaker may be used. You have symptomatic sinus bradycardia, junctional rhythms, idioventricular rhythms, dying heart, astole, a 2-to-1 AV block, Morbitz 2 second-degree AV blocks, third-degree AV blocks, or anti-tachycardia pacing. Permanent and temporary pacemakers. Depending on the patient's signs and symptoms, a permanent or a temporary pacemaker can be used to maintain heart rhythm. Pacing lead placements vary to the patient's specific needs. A permanent pacemaker is inserted when the arrhythmia that necessitates it is thought to be permanent. There are two different types of pacemakers. You have the pocket generator, which is the generator consists of a battery and a microchip circuitry enclosed in a titanium case. It is implanted into a pocket made from the subcutaneous tissue. The pocket is usually constructed under the clavien. A permanent pacemakers are initially programmed during implantation. The program sets the conditions under which the pacemaker functions and can be adjusted externally whenever necessary. Permanent pacemakers batteries are made out of lithium, and they have a duration of lifespan of 5 to 15 years, which kind of makes you think about the batteries, considering we buy a lot of lithium batteries that they're supposed to last 5 to 15 years. But we're constantly going to the store to buy lithium batteries. So this is a diagram of showing exactly where they place the pacemaker. As you can see, if this is the patient's subclavian vein, and it's right under the collarbone or the clavien, and that's where the pacemaker is, and the leads are going through the subclavian vein into the right atria and going down into the right ventricle. Excuse me. Temporary pacemaker. A temporary pacemaker is commonly inserted in an emergency situation only. Temporary pacemakers are used to help the patient get over the hump after an MI or other problems temporarily cause a symptomatic bradycardia. Sorry. A temporary pacemaker can also serve as a bridge until a permanent pacemaker is inserted or can be put in. There are several different types of temporary pacemakers. You have the transvenous, which is a pacing catheter, is inserted into a large vein and threaded into the right atrium and down into the right ventricle. Then you have the epithelial temporary pacemaker and the transcutaneous pacemaker. The transcutaneous pacemaker, which involves large pacing electrodes that are attached to the chest and back to help pace the heart through the chest wall. Both are temporary pacemaker methods are pulse generators at the patient's bed. Temporary pacemakers should have batteries, pacing, thrust holes, and connections between the pacing leads and generator generally checked. And these are the different temporary pacemakers that they have. This is pacemaker terminology. Whenever somebody has a pacemaker, you have different terminology as to the lingo of how you would sense a pacemaker. Firing, when somebody says a pacemaker is firing refers to the pacemaker's generation of an electrical stimulant. It is noted on an EKG by the presence of a pacemaker spike. You'll see a spike either before the P wave is formed or before the QRS is formed, depending on where the pace is set at. Capture refers to the presence of a P wave or a QRS complex or sometimes both after the pacemaker spike. This indicates that the tissue of the chamber being paced has depolarized. Pace QRS complexes are wide and bizarre and resemble PVCs. Sensing. Sensing refers to the pacemaker's ability to recognize the patient's own intrinsic rhythm or beat in order to decide if it needs to fire or not. Most pacemaker functions on a demand mode, meaning they fire only when needed, only on demand. 3-letter pacemaker codes. The capability of permanent pacemakers may be described by a generic 5-letter coding system, although 3 letters are more commonly used now, where the first letter of the code indicates the heart chamber being paced. These are the options and the letters used to signify these options. V, of course, is for ventricle. A is for atrial. D is for dual, meaning both atrial and ventricle. And O means for none. The second letter in a permanent pacemaker signifies the heart chambers in which the pacemaker senses its intrinsic activity. Of course, V stands for ventricle, A, atrium, D for dual, both ventricle and atrial. O, meaning no sensing. When a pacemaker doesn't sense intrinsic activity, it paces even if intrinsic activity exists. This is referred to asynchronous pacing. The third letter indicates the pacemaker's response to the intrinsic electrical activity it senses in the atrium or ventricle. T stands for triggered pacing. For instance, if atrial activity is sensed, ventricular pacing may be triggered. I inhibit pacing. If the pacemaker senses intrinsic activity in a chamber, it won't fire on that chamber. D is dual. The pacemaker can be triggered or inhibited in the atrium, ventricle, or both. And of course, O means zero or none, where the pacemaker doesn't respond to electrical activity whatsoever. All pacemakers used today are on-demand pacemakers or demand pacemakers, to where sensors tell when the pacemaker has to be fired. VVI pacemakers. These are the most common kinds of pacemakers that are used today, which are VVIs and DDDs. The VVI pacemaker is also known as the ventricular demand pacemaker. It has at one time the most commonly used permanent pacer. The VVI pacemaker paces and senses the ventricles. When it senses intrinsic ventricular activity, it inhibits pacing. This single chamber pacemaker benefits patients with complete heart block and those needed intermediate pacing. The VVI mode is also common for patients with a permanent pacemaker who have permanent atrial fibrillation. The VVI pacer consists of a catheter with both pacing and sensing capabilities and is inserted into the right ventricle. The VVI pacemaker paces the ventricle, providing a spike and then wide QRS complex. The VVI pacemakers provides two options. You have the intrinsic beat only, where the pacemaker does not pace because it doesn't need to. The rhythm is fast enough so the pacemaker is inhibited. There will be no pacemaker spike. The rhythm is produced completely by the patient's own heart. And then you have the paced QRS. Dissociate intrinsic P waves. The pacemaker senses and spikes only the ventricle. There will be a pacemaker spike preceding only the QRS complex. Intrinsic P waves is present and will be ignored by the pacemaker. And here's a picture of the two, how your QRSs will look between the two different VVI pacemakers. Next pacemaker, permanent pacemaker we'll talk about is the DDD pacemaker. The DDD pacemaker is the most modern and the most physiologic pacemaker that they have. It is known as the universal pacemaker and now the most commonly inserted pacemaker. It paces and senses both atrium and ventricle. A DDD pacemaker is used with AV block. The DDD has many advantages to it, which includes versatility, programmability, ability to change modes automatically, ability to mimic the normal physiologic cardiac cycle, maintaining AV sequency, ability to sense and pace the atria and ventricle at the same time according to the intrinsic atrial rate and the maximal rate limit. The DDD pacemaker senses intrinsic atrial activity and takes advantage of the patient's own P wave. DDD pacemakers are usually rate responsive, meaning that they will provide a paced QRS to follow the patient's intrinsic P wave within preset heart rate limits. These limits are usually 60 to 125 beats per minute. The DDD pacemaker will not provide a paced QRS for each intrinsic P wave because that would result in a tachycardia which is dangerous to the patient. DDD pacemakers provide 4 options. You have the intrinsic beat only, where the pacemaker does not fire because it does not need to. The intrinsic rate is fast enough, there will be no pacemaker spikes visible. Then you have the paced P wave and intrinsic Q wave, QRS. This is when the pacemaker paces the atrium, providing a pacemaker spike and a paced P wave. Following this, the patient's own QRS occurs. Therefore, a spike only appears before the P wave. Then you have a paced P wave and a paced QRS. This is where the pacemaker paces not only the atrium but also the ventricle to provide a spike before the P wave and a spike before the QRS. Then you have the intrinsic P wave with the paced QRS, where there's the patient's own P wave and then a pacemaker pace will pace out the QRS, and you'll show a spike just before the QRS is formed. And this is a picture of the 2 different paces. This is the DDD pacemaker options between the 4 options that are available. This is where we're going to stop for today's lecture. On Monday, you'll get the 3rd part of this lecture, which will be talking about pacemaker malfunctions. It will also talk about the problems with traditional pacemakers, electrical cardioversion, and defibrillation. If you have any questions about this lecture, please feel free to text or message me with any questions, and I'll be more than happy to help you out. I conclude this lecture, and good night.